Now we are moving on to the next session, that is viral topics, something regarding COVID-19 and all. To chair the session, we have two eminent faculties. Dr. Mohan Nair sir, he is the senior consultant physician and diabetologist from Trivandrum, and my dear friend Dr. Iryna Nair is there. He is assistant professor of psychiatry, medical college Trivandrum. Over to you, chairs.
So good afternoon once again, and we have a very relevant session now. It's termed viral topics. Of course, it's a viral in both senses. It's viral academically as well as it's viral pandemic that we are having, and we have excellent speakers who have basically first-hand information on how to manage these conditions. We have three speakers, Dr. Chandini and Dr. Sunil Prasobh. Both are actively involved in the COVID management scenario in Kerala, and we have a speaker from outside, Dr. Iryna from Ukraine. And I request my co-chair, Dr. Arun B. Nair, to introduce Dr. Chandini and continue with the proceedings. Dr. Arun, please.
Thank you, sir. Thank you, sir. So the first talk of this session is by Dr. Chandini R. She is the professor of medicine and head of Department of Emergency Medicine, Government Medical College, Kozhikode. She is the president of Hypertension Society of India. She has been very proactively involved in the COVID-19 management in institutional and state level, and she has been recognized by the government for her efforts in relation to COVID management. So she is the best person to speak about COVID because probably the person who has treated maximum number of COVID cases, or at least one of the persons who have treated maximum number of COVID cases in Kerala. So with great respect, I'm inviting Chandini Madam to start her lecture. Over to
I think she had also been honored Best Doctor Award last year. I mean, right, Dr. Chandini? Yeah, she had been awarded the Best Doctor Award, I think.
Yeah.
Thank you, Dr. Shabir, for the opportunity to present this topic in this academic forum, and that too after the power-packed presentation by Dr. Bobby Matthew. It's going to be challenging for me. And thank you, Dr. Mohan Nair, sir, and Dr. Arun for the kind words of introduction. I'll be straight away moving to the topic, that is COVID-19 and metabolic disorders. As we all agree, we are into this pandemic, and we don't know how this pandemic and where this pandemic is going to take us. Probably we'll have to live it with this virus for a long time. And we have diabetes, its own unique challenges, and we need to understand the management strategies. Obviously, we need to individualize care, and we need to stay safe. We need to take all the infection control practices for ourselves to be safe in treating these patients. And I have no conflicts of interest for this presentation. And with regard to COVID-19, this is a less known disease. And we must understand there is an asymptomatic or pre-symptomatic phase, and that is causing more infections in vulnerable group. And the death is happening due to ARDS cytokine storm and its cardiac and renal complications. And when we move on to metabolic disorders, I will not be touching all the metabolic disorders. My focus is primarily on diabetes and hyperglycemia because it increases morbidity and mortality in patients with COVID-19. And it's not only hyperglycemia, but glucose variability and hypoglycemia are also going to be challenging situations when we manage these patients. And when we look at the diabetes and COVID-19 link, risk of fatal outcome is increased due to defects in innate immunity affecting phagocytosis, neutrophil chemotaxis, and cell-mediated immunity. There is high prevalence of diabetes in elderly, and advancing age is itself emerging as the strongest predictor of COVID-19 related deaths. And on top of that, we have patients with target organ damage, obesity, obstetric sleep apnea syndrome, fatty liver, and chronic liver disease. All these are giving us challenging situations in managing these patients with COVID-19. What are the reasons for hyperglycemia in COVID-19? We know that the reasons are manifold. COVID-19 infection itself is a challenging situation and it is causing hyperglycemia. The stress involved is huge because most of the patients, when we shift them to ICU, they really believe that they are going to die. And they have seen patients asking, what is the chance? 50-50. So that is the way they have been pushed, and this is a stress involved and stress involved with the disease also. And steroid, most of them, steroid is accepted as a mode of treatment. So steroid is known to cause hyperglycemia. and many of them because of the because of the hypotension and the situations, we need to start them on inotropes, and it is also acting as a counter-regulatory hormone and increasing the hyperglycemia. And the predisposing factor, mainly family history, obesity, insulin resistance, obstructive sleep apnea, all these, including the autoimmunity, is causing hyperglycemia in COVID-19. And when we move on to SARS-CoV-2 infection, we know that uncontrolled diabetes affects the outcomes. We also know that improving glycemic control reduces the adverse outcomes. An increased risk of other infections in ICU if the patient is having hyperglycemia. So we should understand that diabetes mellitus is no longer an innocent bystander, and we need to understand, we need to document, and we need to tackle it on day one itself in all these patients. So that is the important message I would like to share with you. And there are unique challenges with diabetes having COVID-19 because they are at risk for more severe illness, and they may present with severe manifestations of diabetes, especially diabetic ketoacidosis, hyperglycemia, hyperosmolar state, and severe insulin resistance. So we are perplexed by the amount of insulin, the dose of insulin that these patients requiring to control in these situations. And there are enough studies, and there is enough documentation that there is severe progression in COVID-19 patients with coexisting diabetes. These patients go into severe disease, and these patients have significantly higher mortality than patients with non-diabetes when they come with COVID-19 infection. So in COVID-19, the mortality estimate is 1.4 to 2.3%, but we must understand the critical care capacities are really overwhelmed when we get more of these patients, especially those patients with comorbidities and underlying cardiovascular disease and diabetes. So we need to document comorbidities in all these patients whenever they are hospitalized. And always there is a challenge. Most of the patients may need hemodialysis, they may need thrombolysis, they may develop myocardial infarction while in the hospital. The system must have an opportunity to tackle all these issues. So we need to risk stratify these patients on presentation itself, and we need to prioritize palliative care. Which patient should go for the aggressive management and which patient should go for a reasonable palliative care considering these issues. And specific treatment using drugs of unproven benefits and adverse events. That is another challenge. We are using many drugs, and we believe these drugs act in COVID-19 because most of them we use on compassionate grounds, and we don't know what is the drug interaction with anti-diabetic drugs that we have and the COVID-19 drugs that we use. And most importantly, there is a dysregulated immune response and high risk of thromboembolism that is also going to be very, very challenging in patients with diabetes mellitus. And when we know that most of our patients are having high cardiovascular disease risk, and this is all the more important and all the more severe in patients having type 2 diabetes mellitus. And we know that all these are the mechanisms, and we know that these patients are significantly prone for myocardial infarction, viral myocarditis, cardiomyopathy, and tachyarrhythmias, heart failure. So we have to be more careful in managing these patients when they come with COVID-19. And how SARS-CoV infection is really affected with hyperglycemia. We know that acute hyperglycemia upregulate ACE2 expression in cells and facilitate viral entry. And chronic hyperglycemia downregulate ACE2 in cells, hence vulnerable to inflammatory effect of virus. And expression of ACE2 in beta cells had direct effect on beta cell function, and insulin resistance is disproportionately high compared to other infections. So what does that mean? We know that the ACE2 receptors are responsible for the cell entry of the virus, and this helps in viral replication. And this virus itself and the hyperglycemia actually downregulate ACE2. But in patients there is upregulation of ACE2, that is happening in chronic hyperglycemia, and when there is a deficiency of ACE2, we know that the angiotensin 2 to angiotensin 1 to 7, angiotensin 1 to angiotensin 1 to 9, these are good molecules are really decreased when the ACE2 is downregulated, and there is a high risk of acute lung injury, adverse myocardial remodeling, vasoconstriction, vascular permeability because of the angiotensin type 1 receptor which is exposed, which is in fact blocked by our ARBs or by the angiotensin 2 is directly acting on this. And if we really able to downregulate the ACE2, that will be beneficial in these patients, and this is not happening in patients with hyperglycemia. RAS inhibitors and risk of COVID-19 is another important topic that is very much related to hyperglycemia and diabetes, because studies have really shown that previous treatment with ACE, ARB, beta blockers and calcium channel blockers, whatever be the antihypertensive that we prescribe, there is no substantial increase in the chance of a person becoming positive with COVID-19, or there is no risk of severe COVID-19. So we don't have to really stop these drugs when the patient is having diabetes with this drugs as an antihypertensive. So drugs and COVID-19, we should understand, we should continue treatment with ACI and ARB if there is no other reason for discontinuation like hypotension or acute kidney injury. But definitely we should understand NSAIDs is to be avoided and avoid nebulized medication. That is what is really prescribed in patients with COVID-19 has to be followed with diabetes also. So how do these patients present? Diabetes and COVID-19, it's very, very interesting. There is myriads of presentation. And we have seen maybe about 50 to 60 patients in the ICU, but I have seen all the types of presentation with diabetes and COVID-19 in this ICU. A1C and self-monitoring of blood glucose are the only tools that we have to assess what is the duration of diabetes, what is the risk of this patient having this hyperglycemia for them as with regard to morbidity and mortality. This patient could come with stress hyperglycemia, because even with 18-year-old female, very lean, with normal BMI, with no family history of diabetes, blood glucose has been going to 200 and above. That was really perplexing with regard to management of diabetes. Pre-diabetes is very common, HbA1c between the 5.7 to 6.5 range. Diabetes undiagnosed or diabetes already diagnosed. And we also see patients with advanced disease with diabetes, for kidney disease requiring dialysis. While on hemodialysis, they have been admitted. There are patients with cardiovascular disease on PTCA, on CABG, coming with COVID and developing infarction, chest pain, and all these things are happening in our clinical practice now. So we need to be very careful in monitoring these patients. Hypoglycemia, especially hypoglycemia unawareness, is a very real challenging problem. So we have to be very careful when prescribing insulin in these patients. So all these patients require a very close monitoring while in ICUs. So how do we do this? Examination during COVID-19, it's very, very challenging. Communication is a real problem. So we don't have the real time to discuss with the diabetes care, diabetes management and all those issues in patients with COVID-19. So we have to be more careful when using words, because the words are the only way of communication in these patients, because most of the time in PPE in the ICU, people are really frightened and we have to be very careful with this regard. An initial assessment and emergency stabilization is needed, because we need to see what is the cardiovascular and renal status and all those complications, hypertension or whatever these patients are presenting to us. And there are a lot of challenges in examination, monitoring of these patients. So we need to have proper insulin documentation, insulin charts. We need to know what was the insulin the patient is receiving for the last 24 hours, whether there is any hypoglycemic episode. So the documentation is very, very important, because patient most of the time it will be difficult to communicate. And trials to feeding, whatever be the feeds, and most of them will not have any bystanders, even in wards. We don't entertain bystanders because of the risk of transmission. So we have to know, we have to be very careful about their feeding, and we need to be very careful in avoiding hypos. So there should be strategies appropriate to the hospital when we manage these patients. And there is a list of investigation, because there is a high risk of thromboembolism, there is a high risk of pre-existing heart disease, myocarditis. All these investigations are very, very relevant and important, and we need to interpret appropriately so that we can modify the management in these patients. And what is the target therapeutic goals? It is about fasting in the 80 to 130 and PPB postprandial maybe less than 180. We don't want to push them into hypoglycemia. And what we need is an optimum glycemic goal without pushing them into hypoglycemia. And what are the drugs that we can prescribe in these patients? Metformin, if the patient is very well stabilized and a milder disease, not requiring hospitalization, asymptomatic or mild symptoms, definitely we can continue metformin, but in a hospitalized patient, always better that we stop metformin. SGLT2 inhibitor, there is a risk of dehydration and diabetic ketoacidosis, especially euglycemic DKA is well known, and we have to avoid initiating therapy during respiratory illness in all these patients, especially in the hospitalized situation or patient coming with a severe illness. We should refrain from prescribing this drug. DLP-1 analog, if the patient is already on this drug, definitely we can continue, but DPP-4 inhibitors may be safer because there is no risk of hypoglycemia. But all hospitalized patients, it is always better and prudent that we start on insulin and maintain the glycemic status on insulin. How do we monitor? Regular self-monitoring of blood glucose is very essential because we need to see what is pre-breakfast, pre-lunch, and pre-dinner, and we need to avoid hyposulfonylureas, milder illness. Definitely, we can continue if the patient is well controlled, but be on the watch for hypoglycemia. A1C is a tool that will help you what is the type of diabetes that we are dealing with. Definitely there could be immunosuppression, autoimmunity, worsening glycemic status, and most of these patients are mechanically ventilated or drives to feeding. So feeding must be monitored and it is all under our control what this patient is going to take, or it could be enteral feed or rice to feed. We have to monitor appropriately, and daily monitoring is the key for proper maintenance of glycemic goal. And in hospitalized patients, we can go with regular, or if the patient feed, it's not in our control, or the meal timings are different, or meal is arriving late, we can go for faster acting insulins, and NPH for the basal bolus regime will be the appropriate one. Diabetes and CKD, it's a major challenge and we are facing it every day. Most of them are coming with CKD, with dialysis or on maintenance hemodialysis already. And I have only 2 hypos among these 50 to 60 patients with diabetes. We have managed very serious illness in the ICU. And this both 2 hypos happened in CKDs, and this is detected just by 3 a.m. monitoring. So the monitoring, I just put this because monitoring is very important, and hypoglycemia unawareness is very well documented. So we have to be very careful in managing COVID-19 and diabetes. And we have different scenarios. Patient may be neurally, so they don't need meal-related insulin. What we need is only basal insulin. There may be postprandial hikes only, especially in stress hyperglycemia, so we can balance with a bolus dose of insulin. It could be a regular insulin or it could be a faster response or faster insulin analogs. And some patients will need only bolus insulin. So some patients will need the conventional basal and bolus regime. So we have to manage depending upon the need and depending on the type of hyperglycemia. It's not the one way for the all patients, the one prescription that will not hold good. So we have to be very careful in prescribing. So we need to understand challenges. We need to estimate our facilities, our manpower, knowledge and chance of human errors is also very high because the people will be rotating. The manpower is a huge challenge in all of these ICUs. So there could be errors with insulin and prescription. So we have to be very, very careful. And we have to emphasize that all the people involved in diabetes care are really educated and adequately trained. Meal timings may go beyond our control. Goals we have to individualize. There is high risk of hypoglycemia, unawareness is well known. So monitoring should be more frequent, and that is the only way that we could achieve the optimal glycemic control, and we can titrate the drug appropriately, and we need to provide psychosocial support. Vulnerable groups in elderly, especially there is delayed ED visits, there is delay in procedures because they come late, and admissions in wrong places because of dementia, because of mass clinical presentations, COVID, non-COVID, all these issues happen. And the admissions and isolation really posing a big challenge in elderly people. And missing treatment for comorbidities is really increasing the risk of death in these patients. So we have to be very careful, especially in vulnerable groups. And what are the severe disease indicators? It is just the same in COVID-19. We have to be very careful about hypoxia. We have to be very careful of the need for oxygenation, timely initiation of ventilator support or oxygen therapy. And we need to warrant long-term follow-up because it is already known that this patient go for fibrosis of the lung. So they may need long-term follow-up, and this is also the major challenge. So, okay, so this is how we need to do, and we need to individualize care. And there are positive evidence from clinical trials. So we have to use most of them compassionate and looking at the challenges, we need to optimize the dose. I have been trying to take you through some of the aspects, and most of them are known, or most of them are really, we are learning it. We need to follow up and we need to modify our knowledge in the coming days. Thank you so much.
Thank you very much, Dr. Chandini, wonderful presentation. And since that we are running short of time, can you please stay back till the whole session for any questions?
Yeah. Thank you, sir. Thank you, sir.
Chandini, can you please stay back? Then we can move on to the next session, next speaker, none other than Dr. Sunil Prasobh. Dr. Sunil Prasobh, he is the probably the most promising upcoming academician. And currently he is the additional professor of internal medicine, Government Medical College, Kollam, and he had been an alumnus of my alma mater, that is the Trivandrum Medical College, from where he did his MBBS as well as MD. And incidentally, he was my classmate for the postgraduate diploma in diabetology in Annamale University. And he currently was associate professor in Trivandrum Medical College. He is a fellow of Royal College of Physicians and fellow of American College of Physicians. And he had also his postgraduate program in diabetology from Johns Hopkins University and certificate course from the MDR of Chennai. And over to Dr. Sunil Prasobh, who will be sharing his experiences in COVID management. Over to Dr. Sunil Prasobh.
Thank you, Mohan Nair sir, Arun, and thanks, special thanks to my very dear friend Sabir for this fantastic opportunity. So my topic is basically based on recent updates on COVID management. We all know diabetes, the corona is growing in epidemic proportions. And if you look at the present statistics, you can know worldwide statistics says that around 6 lakh, more than 6 lakh people are affected in India. And if you look at the death rate in India, around 4 lakh 30,000 people have already died. So it is definitely growing in epidemic proportions. And the WHO has declared it as a world pandemic in March 11, 2020. This is basically an iceberg disease, just like diabetes we see. Around 80% of the patients are often misdiagnosed, not diagnosed, and around 5% becomes critically ill. And the case fatality rate of this COVID infection is to the tune of 4 to 5%. The most important risk group as far as COVID is concerned is basically 3. The people who are aged above 65 years, people who live in nursing home or long-term care facility, and people with comorbidities like the obesity, severe obesity, uncontrolled diabetes, hypertension, COPD, immunocompromised patients, pregnancy. All these are high-risk group. But the most important aspect that we all should understand is all patients who develop viremia may not go in for a very, very difficult stage. For that, the immune system of the host is very, very important. We do have 2 types of immune systems, the innate immunity and the adaptive immunity. The innate immunity mediated by the interleukins, interferons, the natural killer cells plays a very, very important role initially. By the time the COVID attack happens, the innate immunity fails to respond in the initial stage. And that is the reason why the adaptive immunity also fails. The adaptive immunity is basically mediated by the T-cell mediated immunity and the plasma cell mediated, antibody mediated immunity. The adaptive immunity also fails, and the dysregulated adaptive immunity plays a very, very important role in the development of cytokine storm syndrome. The cytokine storm syndrome can either be localized or diffuse. And the localized cytokine storm syndrome usually happens to lungs, most commonly heart, endothelium. If it happens in a diffuse manner, it leads to multi-organ dysfunction. As Chandini madam already told, the AC2 receptors play a very, very important role because the SARS coronavirus attaches to the AC2 receptor present on the surface of the cells. These AC2 receptors are present in a wide variety of areas, predominantly in the upper respiratory tract, also in the lungs, intestinal tract, even in pancreas, these AC2 receptors are there, and it plays a very important role in determining the severity of the disease. This Chandini madam has already alluded, the ACE2 pathway and the ACE pathway. The ACE pathway is actually very, very bad because it causes vasoconstriction, hypertension, cardiac hypertrophy. And homologous other pathway is the ACE2 pathway, this ACE2 pathway. This ACE2 pathway is actually good because it causes vasodilation and it is actually protective. But when we give AC inhibitors or the RAS blockers, what happens is there is an upregulation of the ACE2 pathway. So we think that ACE2 pathway may be good, but unfortunately the virus entry happens through this ACE2 pathway and there will be a downregulation of the ACE2 pathway. So although there is an upregulation of the ACE2 pathway, on the other side, there will be a downregulation by the entry of the SARS coronavirus. So that is why the reason why all guidelines have said that we can continue with the RAS blockers. So who all are the high-risk patient groups? Definitely the patients with comorbidities, which I have already told. Then the clinical assessment, the patient initially with hypoxia, tachycardia, respiratory distress, hypotension, and the initial lab parameters also very, very important because other than the usual routine blood checkup, we specifically looking for the inflammatory markers like the C-reactive protein, ferritin, D-dimer, troponin T. Because as I have told you, when the inflammatory markers are very much elevated, we should suspect a cytokine storm. This is what the national guidelines say. We should categorize all the patients who are coming to us to mild, moderate, and severe. Mild is basically uncomplicated upper respiratory tract, moderate is pneumonia, and severe is severe pneumonia. Mild people usually don't have hypoxia, and the moderate will have a respiratory rate of more than 24, SpO2 in the range of 90 to 94. Severe people usually have an SpO2 less than 90 and respiratory rate of more than 90. Patients with ARDS, sepsis, septic shock, multi-organ usually come under critical group. So this is the natural history and the natural progression of the disease that we see. By 8th day, most of the patients who progress to a severe stage get admitted. And one of the most important thing is by 10 to 12th day, the patients who go in for a cytokine storm can develop ARDS. This is a classic X-ray picture that we usually see, the ground glass opacities, the peripheral ground glass opacities in the X-rays and CTs we see. Initially, we thought that SARS coronavirus basically concentrated on the lung itself, and most of the patients had ARDS and pneumonia. But now it's a disease which affects many of the systems. It can affect the heart, kidney, and cause sepsis. So many other problems are there. When time has gone by, we do have more tests now. We do have the nuclear amplification tests like RT-PCR, TrueNat, CBNat, and the RT-PCR is a gold standard test for diagnosis. The rapid antigen test has come in handy because we use this test to test people in hotspots and containment areas. The results comes in very fast. Then there is rapid antibody test used for surveillance. The natural history of the COVID, if you look, there is an initial stage of viremia, second stage of pulmonary phase, and the third stage or the late stage is a hyperinflammation stage. This is what is more important. In the initial phase, the antivirals are effective, and in the late stages, anti-inflammatory drugs are very effective. So if you look at the treatment and the evidence, there are only indirect evidence and observational studies and RCTs, not so convincing. We have to wait some more time. So if you look at the drug armamentarium, there is antivirals, which the most noticeable ones are HCQs, remdesivir, and favipiravir. And if you look at the anti-inflammatory and immunomodulators, there is glucocorticoids, dexamethasone, convalescent plasma, and tocilizumab. This is how the antivirals act. The hydroxychloroquine, which is a fusion inhibitor, it inhibits the multiplication of the virus. The lopinavir, ritonavir, which is not used, this is a viral protease inhibitor, and the remdesivir and favipiravir is a viral RNA-dependent RNA polymerase inhibitor. So these are the usual viral drug antivirals which we use. The HCQs usually used in mild to moderate disease, given as oral tablets. But the most important thing is the QT prolongation. We should be very, very cautious about this. Then the drug which we use these days is a remdesivir, usually used in moderate disease patients who are not responding to adequate oxygen, usually given as intravenous injections. The most important thing is the QT prolongation. Again, QT prolongation should be the most important thing and looking for. Another contraindications are renal failure, hepatic failure, pregnancy, lactation, and other QT prolonging drugs. The favipiravir, although it is approved, not used these days because the pill burden is more, it is usually indicated in patients with moderate disease, and it is given orally. And in one important portion is hyperuricemia, but this is not used these days. If you look at the evidence, there are so many evidence coming in for HCQs. The initial enthusiasm which was there initially is now not there for HCQs. And we do have a very large trial. It is funded by the Solidarity trial. The WHO funded Solidarity trial will give an answer to our question regarding whether it is a remdesivir, HCQs, lopinavir, or interferon. All these things are studied in a big way in the Solidarity trial. One very important trial which came recently is the recovery trial, which showed that steroids, especially the dexamethasone, is a very, very useful drug because it reduced the mortality in severe patients to the tune of 30%. The steroids, glucocorticoids, dexamethasone can be given intravenously and is usually indicated in moderate to severe disease. Another very important drug is the tocilizumab, which is a human monoclonal antibody against interleukin-6. It is usually indicated in moderate to severe disease with very, very high inflammatory markers. Another important treatment armamentarium which has come handy these days is a convalescent plasma, which is usually indicated in moderate disease patients who are not responding to adequate oxygen, but the ABM compatibility and also the post infusion, we will have to wait to look whether there are allergic tendencies. Cytokine storm is very, very, very important. What we all should understand, the simple viremia is not going to kill the patient. It is a cytokine storm induced complication that is the one which is going to kill the patient. And the most important treatment of CRS is tocilizumab and steroid. These are some of the drugs, antiviral drugs under study. You can see so many antiviral drugs are, and the noticeable ones are the camostat, nafamostat, which are fusion inhibitors, and there are so many other drugs under study. And if you look at the immune active agents which are under study, this is leronlimab, JAK inhibitors, ruxolitinib. Along with this, there is the intravenous immunoglobulin, the itolizumab, then anakinra. So many other immunological agents are being studied in COVID. And this is the national guidelines. I think most of you might be knowing this is a very busy slide, and this is a simple format of this national guideline. Mild cases, you can treat the patient in corona care unit or home. You can give HCQs in high-risk patients. In moderate patients, you can treat it in a dedicated corona hospitals. Then oxygen will have to be given. HCQs you will have to give. You can treat with steroids, either methylprednisolone or Dexona. Anticoagulation is also necessary. In severe cases, definitely those severe patients will have to be treated in a tertiary care hospital known as the COVID hospital. Increased oxygen requirements in these patients. Ventilation is a very, very important part. We will have to treat with steroids and anticoagulations. And the national guidelines have put this remdesivir, tocilizumab, and convalescent plasma in investigational therapies. Another very, very important aspect is the oxygen therapy. The oxygen therapy, whenever the SpO2 comes below 90, we will have to initiate oxygen. You can give different modes of oxygen, the nasal prongs, the Venturi mask, the non-breathing face mask. And one of the most important the method of oxygen delivery which has come really handy in this COVID era is the high flow nasal oxygen, where you can give oxygen to the tune of 60 liters per minute. If the patient is not if the patient does not become better with a high flow nasal oxygen, you may have to go in for a non-invasive ventilation, and if not corrected, you may have to go in for a mechanical ventilation. This is what I told. High flow nasal oxygen has become the dictum in most of our tertiary care hospitals. Another very important aspect is the proning. This cartoon clearly elaborates how it is being done. And the ideal way, you can keep the patient 1 hour in prone position, left lateral position, right lateral position, upright position. By proning, we can improve the ventilation perfusion mismatch in the people, and also we can make the dorsocephals of the lung more active. So proning has definitely improved these days the life of many patients. Another thing we should be very, very careful is the aerosol generating procedures, the intubation, the non-invasive ventilation, bronchoscopy, the drilling surgeries done by the orthopedicians. All these are very, very dangerous because they are aerosol generating. The comorbidities, Chandini Madam has beautifully covered. The diabetes, insulin is the treatment of choice. Hypertension, you can continue with the RAS blockers. And the COVID and the heart, the most important manifestations are myocarditis, acute coronary syndrome, arrhythmias, endothelial dysfunction, and hypercoagulability. This endothelial dysfunction was a reason why we read that there was an incidence of Kawasaki syndrome in some of the Western countries and was noticed even in Mumbai. Hypercoagulability is one another important because COVID is a condition which is thought to be like a DIC-like situation, a procoagulant. So multiple thrombosis is always a possibility. In respiratory system, always continue with steroid inhalers. The coagulability, the increased coagulability and COVID is now known as the CAHA, corona-associated, the COVID-associated hemostatic abnormality. And this COVID-associated hemostatic abnormality, the thrombosis can happen, particularly the lung, the small vessels of the lung and the large vessels of the sun. The small vessels of the lung, it can cause inflammation, thrombosis, inflammation, and ARDS. If it happens in a large vessels, it can predispose to pulmonary embolism. And the treatment of choice is heparin. So how can we conquer COVID-19? We all know the social preventive methods that we adopt, the development of treatment, the repurposed drugs, the passive immune therapy, the convalescent sera, the human monoclonal antibodies. But the definite answer or a genuine answer to this will be the vaccine. We will have to wait some time for the vaccines, but we do have highly optimism as far as vaccine is concerned because several studies are going on. The RNA virus, the live attenuated inactive vaccine, subunit vaccine, viral vector vaccines. These are some of the frontline vaccine, Moderna vaccine from US, the Oxford vaccine from UK, which is a viral vector vaccine, then Pfizer vaccine, the Sinovac vaccine, which is an inactivated vaccine. The India is not far behind because we do have vaccine known as Covaxin. It is being developed by the Bharat Biotechnology in association with ICMR and NIB. So in the last 5 months, we have learned a lot. We know about the happy hypoxia and the hypoxia it causes. Oxygen is a definite treatment for this thing. Prone positioning is also very, very important. The tests have improved. The number of tests has increased. The nucleic acid amplification test, the antigen test coming in, the results coming in very quickly. The pulmonary vascular thrombosis, the CAHA, the cytokine storm, which is a real cause of death of many patients, and then the drugs like remdesivir, steroids, convalescent plasma, tocilizumab. All these have helped in decreasing the mortality in our patients. But we do have several concerns like the ICU facilities, the PPE, the ventilators, and the community transmission is really staring us. Well, this is the thing that we have seen. Initially, everybody was in a panic mode, but when the number of cases increased, everybody changed to a picnic mode, and that is the result that we are now facing. But in spite of all these things, we should still have to adhere to the social distancing, sanitizing, hand mark, and the preventive measures because it still works now. Thank you for your patient listening. We will take up a few questions later.
Thank you, Dr. Prasobh, for that extremely lucid, clear, very enlightening, and very practical presentation from all points of view. So let us go to the next speaker. We have got an international speaker as the next faculty. She's none other than Dr. Iryna Vilasenko, who is the Vice President of International Speciality. She is the Associate Professor of the National Medical Academy of Postgraduate Education in Ukraine. She is a member of the European Medicine Agency, EMA, and she is a co-author of the celebrated book, Self-Management of Training of Patients with Diabetes. And she was also the director of the first International Diabetes Football Championship, which was titled Dio Europe, which was conducted in 2012. So Dr. Iryna, we are extremely privileged to have you here in our forum as the speaker today, and she would be enlightening us on the very relevant topic, COVID-19 and diabetes, the challenges and perspectives. We would love to hear you talk about the global perspectives and your experience with regards to the management of diabetes in the background of COVID. Over to you, Dr. Iryna.
Thank you. I would like to say big thanks to Dr. Rasheed for this opportunity. This is second conference. Last day I was involved in another Indian conference, and now I'm feeling that I'm in India, very close with you. I'm very happy because I interested Indian culture from my childhood. Thank you so much. Now we will talk about COVID and diabetes. It's challenging not only for doctor and patient, and also for our a big organization like International Diabetes Federation. And as Vice President of this organization, I would like to show our resource, our possibility, and what we will do, and our challenge and perspective. I like join global effort to reduce risk for people with diabetes during COVID-19 pandemic. And if you go to our resource, you can find many documents. You can find links which with collaboration with other organizations, is very professional and not government organization. You can find the recommendation.
Ma'am, Dr. Iryna. Ma'am, can you kindly share your slides? Ma'am, slides are not. Slides are not visible. Can you kindly share with slides?
And this is about our thing to do for people with diabetes. You can find a lot of recommendation. It was developed with another professional organization, and I would like to see COVID outbreak guidelines for people with diabetes, which was created by IDF Europe region. And if you look this time, this is ending on April, and we have already done this. But we know that, next slide please. We know that scientific publication related to the risk of cause severity with COVID-19 in people with diabetes will help to lobby
Next slide. Next slide, please.
for evidence-based policies. And the IDF President-elect, Professor Akhtar Hassan, has edited a special issue of diabetes research and clinical practice, its IDF official scientific journal, the special issue addressing the important topic of diabetes and COVID. And you can find in this scientific and evidence article in this journal and about different aspects in coronavirus and diabetes. And this is very good use because the journal reputation is grown because in content being quoted widely in scientific journals. Next slide, please. Thank you for my colleagues who explained big risk and for people with diabetes. And we now it's half year we live with coronavirus, and a lot of scientists make some research, and I want to underline diabetes associated with COVID-19 mortality risk in large UK study, and that it shows that this risk diabetes for coronavirus. And next slide, please. Yes, this more research shows that this can increase COVID-19 severity. Many people has another disease like cardiovascular disease 30%, and disease close followed diabetes 32%, and chronic lung disease 19%. But we have also good news that people who has normal glycemia control has less mortality. In this case, we must make right the message to people with diabetes. Next slide, please. And you must of course you treat people, and you must give recommendation, general recommendation. But my point, you must underline diabetes management, and this is recommendation must include many aspects, and also in physical and mental health, exercise. And now we in IDF Europe organized new questionnaire about influence COVID-19 of diabetes management, and we soon will get results. And also you must give recommendation if person sick get treated quickly. And of course my colleagues before explain how it's very important check ketoacidosis, because it's also possibility more risk. And next slide, please. Your suggestion must include practical suggestion. And of course, you understand very deeply situation with people, but sometimes people don't understand, not take a lot of attention for this. And your suggestion must be practical and even include very simple, like make sure that you have good supply of diabetes medication you need. Think what you would need if you will be in quarantine in few weeks, and even simple suggestion, but it's very important that make sure that you have access to enough food. And this is information result of studies sent to me yesterday Indian colleagues, Trivandrum, that reverse quarantine and COVID-19 to reduce the mortality and morbidity associated with coronavirus. These people also must know that you must explain to them and they will be decided. This is very good for infectious disease. Next slide, please. And the next challenges, also mental health response. You know, stress and anxiety for both people with diabetes and healthcare professionals. People with diabetes are worried about being infected with coronavirus and what this means for their own health and well-being and also for that of their families and loved ones. And the healthcare profession are concerned about becoming infected and affecting their immediate family and not being able to perform their regular roles in patients' care. I find very good resource like Australian Diabetes Federation make resource for help, for support this both category of patient and healthcare professional. Next slide, please. But this big significant impact COVID-19 impact to health services for non-communicable disease. Access to insulin and diabetes supplies in some countries restriction imposed to tackle the spread of the COVID-19 pandemic and distribute the supply chain for insulin and other essential diabetes medicine. And IVF is activity monitoring issue, Iryna, arising helping to determine what assistance can be offered. Next slide, please. And this is very important. WHO found a study which involved in 155 countries that related with diabetes complication, like 50% make weak nation and interpreted service for treatment of hypertension, cancer treatment, and cardiovascular emergency. This is, I think, is the most important topic, and we must underline on this because this is also increased mortality because many appointment was cancelled and we cannot support people as usually we did this. And this is having a great impact and should be changed. Next slide, please. And this is also big challenge. And if you remember that 2006 we got United Nations resolution about diabetes. It was first time in case not communicable disease, and before it was infection. And we make alliance, and we are part of alliance not communicable disease. And this is in this area we make a lot of progress. But in this time, this pandemic may reverse this trend, and we must work together and need focus on broadcasting of the message that diabetes increased in the prevalence. But if we manage this, we can have good result and outcome result of treatment. Next slide, please. I cannot say, I must say about also virus. Thank you for my colleagues who explained before, but I want only like general say that after the January 10th, after the when scientists in China announced of complete genetic make-up of the novel coronavirus, after this rise to produce vaccine, to develop vaccine forward began. We know many producer promise that we will have vaccine. It's from message from USA after the 12-18 months. But another expert says that it's very optimistic prognosis. And normally the vaccine development takes 8 or 15 years. And I know only one case, it's only 5 years was development of one vaccine. But this is another case, maybe we got earlier than usually, because a lot of resource, a lot of money involved in this. Next slide, please. This is analysis of landscape of COVID-19 candidate vaccine, which published by WHO. This many candidate vaccines, principal evaluation, and also some of them 26 candidates in clinical evaluation. And as you know, some of them maybe in soon go, but we don't know about that. Next slide, please. Following approval, the vaccine can be manufactured, and the WHO make judge many countries, like 150 countries, who like facility about global access facility to vaccine. Next slide. Now, global challenge vaccine. If you see, yes, vaccine soon as possible, but we have anyway challenges. For example, the repeat clinical trials program, Speciality, we don't know about result. Manufacture, it's not only a cost and economical available, and also even packing material. It's not enough glass, and now it's a lot of prediction and a lot of message that we must more product something. This distribution, cost, economics available. Who will be decide who get this vaccine? This also a big challenge. And you know, the anti-vax movement, vaccination and law. I am a member, you present me, I am a member of European Medical Agency Patient Consulting Group, and we speak about vaccine, how improve situation with vaccination from last year, but it's of course not about coronavirus. But this is a situation very dangerous for the world, and because very strong anti-vax movement. But anyway, we must also thinking about vaccination and law. There's no obligation. And challenges, how effective a vaccine will be against mutating coronavirus. We don't know about this. And of course, related with our diabetes, influence vaccination on people with diabetes. We don't know how it will be conditioned, how glycemic influence on glycemic control and complication. Next slide, please. I hope I make a big picture that we have a lot of challenges, and we must work together, and we must to learn how to live with coronavirus, and how help during this situation people with diabetes. And we can of course use and improving telemedicine and consultation, video consultation. This help to save patients. I'm hope that we can do this. Thank you so much for your attention. Next slide, please. I want to share my picture from Ukraine. I hope after the stop coronavirus, welcome to Ukraine. I'll be very happy introduce with my country. Thank you so much for attention.
Thank you, Dr. Sabir, and thank you all the organizers. Thank you, and all the speakers. Thank you again.
Thank you.
I think, thank you everyone. That was a wonderful lecture on COVID-19 and associated conditions.